Thank you, Kshitij, for the tireless background work in putting this program together. Thanks also to WFPI and ASPNR. Since I've got 20 minutes, it's very hard to pick up anatomy and malformation. So what I've done is I've um, concentrated on malformation since that was the brief, and and in locations where anatomy is required, I've put in a few bits about the pertinent anatomy. So I'll start off with lamination of the neuroparenchyma. Ever so thankful to Camilo for putting that picture up, made my life easy. Embryology and disorders of dorsal induction, of ventral induction, malformations of cortical development, and then classic commissural agenesis. So I will rush through this slide, which is of the lamination, which has 5 layers starting from outside in its cortical plate, then the subplate, the intermediate zone, the subventricular zone, and the ventricular zone. You will notice a stark difference between the image put up by Camillo and mine. We do our scans on 1.5 Tesla. So until 20 weeks of gestational age, we discern 3 layers. After that, it's about from 20 to 28, it's 5 layers. And on the diffusion weighted imaging, we are able to appreciate alternating bright, dark, and bright laminae. So obviously the bright foci are those areas which are cell rich, and the dark is obviously the one that is cell sparse and probably made of extracellular matrix. So let's start with dorsal induction. At 3 weeks, the neural folds appear and they form the tube. At around 4 weeks, the closure begins in the mid dorsal region, and as a zipper, they move craniad and caudad. The anterior neuropore closes first, followed by the posterior neuropore at 4 weeks. And after the closure of the neural folds to form the neural tube, you have the notochord there. You have these dark stippled areas pointed to by the blue arrow. That is the neural crest cells. Now, these are very important for the formation of the craniofacial skeleton. Also, very, very important to note that while in a normal fetus, the fusion of the neural folds begins in the mid-dorsal region and then it progresses craniad and caudad. But occasionally, you can have abnormalities that defy the norms, and hence it is important to understand that the neural fold closure can happen at multiple sites. So these numbers here are areas where the neural fold closure begins. So 1, 2, 3, 4, and 5. So if there is an absence of a fusion at junction 2 and 3, you develop a frontal or a prosencephalic encephalocele and so on. You develop at various junctions these encephaloceles. So it is said that anterior and posterior defects occur at around 50 and 60 days respectively, and these are defects that occur because of defective closure of membranes rather than defective closure of the neural folds. Very important to remember that. So in that context, we did an ultrasound where a ventriculomegaly and thin neuroparenchyma were detected at 18 weeks. A fetal MRI at 1.5 Tesla, a sagittal T2 there shows an encephalocele, ventriculomegaly, thinning of the neuroparenchyma, so thin that it is not possible to assess the lamination. And then we have the coronal, where there is a pressure erosion of the septal leaflets secondary to the ventriculomegaly, and hence you have a low fused fornicial pseudonodule. And that's a postmortem MRI, coronal T2, that shows the herniation of the neuroparenchyma through the defect. So this is a case to illustrate the multi-site closure of the neural tube. Ventral induction between 4 and 8 weeks. At the end of 4 weeks, you have the primary vesicles that appear, the prosencephalon, mesencephalon, and the rhombencephalon. Between 7 and 8 weeks, the prosencephalon is now able to divide into 2 telencephalic vesicles. Then you have the diencephalon, the mesencephalon, the metencephalon, and the myelencephalon, and also the flexures become evident. This is between 4 and 8 weeks. Now, if there is a failure of cleavage, what you develop is an alobar, or you develop a holoprosencephaly. This was an ultrasound diagnosis of an alobar holoprosencephaly at 19 weeks gestational age, where you can see very nicely the monoventricle that is in communication with a dorsal cyst. There is absence of the interhemispheric fissure and hence the falx. The cyst is an evagination of the velum interpositum. It is lined by ependyma, and that ependyma is just underneath the meninges. It's occupying the area of the prosencephalic and the diencephalic ventricle. So this is the dorsal cyst, whilst this is the monoventricle, and they are in communication with each other. There is also fusion of the basal ganglia. That's a coronal T2 weighted image. And that's the postmortem MRI, which shows the monoventricle in communication with the dorsal cyst. It is said that the midline abnormalities associated with cysts, for example, it could be a alobar holoprosencephaly with a dorsal cyst. It could be an agenesis of the corpus callosum with an interhemispheric cyst, or it could be a huge porencephalic cyst. Now, how do we differentiate between these? The fact that you're having a tentorial dysplasia veers the diagnosis in favor of a holoprosencephaly. Tentorial dysplasia is diagnosed by the absence of a vein of Galen and straight sinus, which you can see here. Other structures that develop between 4 and 12 weeks. So at between 5 and 8 weeks, the palatal shelves fuse to form the hard palate. The choroid fissure in the eye at 5, between 7 and 8 weeks, the optic nerve develops. Vasculogenesis between 4 and 11 weeks. Between 3 and 8 weeks, we have the pituitary gland, and between 5 and 12, the olfactory bulbs. The point behind this slide is to drive home the point that you could have several pathologies occurring at the same time because of several structures that develop in that period. So you could have, for example, Camilo showed a case of Charles syndrome and several other syndromes where you have associations of various structures. And these will overlap with the neuronal migration period as well. So it's very important to remember the embryological changes that occur at different points. So now that brings us to an ultrasound diagnosis of agenesis of the septum pellucidum on a 30-week scan. This one was an indigenous patient from who was lost to medical treatment and somehow went into the hospital at 30 weeks. And an ultrasound demonstrated that, and they sent her to us. So the axial T2 demonstrates absence of the septal leaflets. And when you have absence of the septal leaflets, what happens is the fornices lose their anchor point. They start to drop down and fuse, and that's why it's called the fornicial pseudonodule. So once we've seen that, now we are obligated to identify is there optic hypoplasia? Does it make it the de Mauzière syndrome? So Stacey Gorgon from Melbourne and her group put out this very nice paper called the 5 spots sign. So what that means is between 40 and 40 weeks, you need to, on an axial T2, be able to discern 5 spots, which are the optic nerves, the internal carotid arteries, and the pituitary stalk in that single plane. And they need to be the same in terms of their dimensions. Between 14 and 40 weeks, this sign holds good. So we diagnosed on the basis of that optic nerve hypoplasia, and this is the postnatal MRI of that same child, axial and coronal T2 weighted images demonstrating optic nerve hypoplasia. Now let's move on to malformations of cortical development. As you all know, it is classified into various categories. The first one is where there is abnormal cell proliferation or apoptosis, which is further broken down to microcephaly and megalencephaly. Obviously, microcephaly is where we have reduced proliferation or increased apoptosis, and the converse for megalencephaly. A little bit about embryology. You have neural progenitor cells that sit in the ventricular zone. Initially, they go through a phase of symmetric division so as to increase the pool of the neural progenitor cells. So one neural progenitor cell will give rise to 2. After a while, the neural progenitor cells undergo an asymmetric division in that one of them will give rise to one neural progenitor cell and a neuron. the neural progenitor cell will continue to divide and enter the subventricular zone, whilst the neuron use the radial glia to migrate. So, if there is reduced proliferation or increased apoptosis, you develop a reduced neuroparenchymal volume, or in other words, micrencephaly. That is what the ultrasound identified as a reduced head circumference at 31 weeks. That set into motion the genetic testing, and we got the diagnosis of an ASPM mutation even before we embarked on this fetal MRI. So we have an axial T2 and a SACH T2 here, which shows a simplified gyral pattern, a normal cortical thickness, a reduced neuroparenchymal volume, and a craniofacial discordance. And that was confirmed on a day 29 postnatal MRI. Myelination progresses as per normal. The volume of the white matter is reduced. So this is ultrasound diagnosis of reduced head circumference, microcephaly. Ultrasound diagnosed distortion of the anterior interhemispheric fissure in this pregnancy of 20 weeks and 4 days. Now, that's an ultrasound image that I have turned and brought it in line with how we view the eyes. So what we've seen there is this distortion of the anterior interhemispheric fissure. And that was referred to us for what is the cause of the distortion. We did the MR and we could see a subtle deviation, which was basically reproduced whatever the ultrasound showed. But what we added was absence of normal lamination in the hemisphere on the left side, which is shown on the coronal T2 weighted image. You can see the normal lamination here, but lack of that normal lamination on the contralateral side. Increase the bulk of the parenchyma that is contributing to the deviation of the anterior interhemispheric fissure. But despite all of that, there is no effacement of the ventricle. In fact, ventricle on the side that is affected is enlarged. We also picked up a few dark T2 dark nodules along the ependymal lining of the end ventricle, which on the EPI shows areas of blooming, and there's this subtle area which is further in from the ependyma within the lumen, which is also blooming. The ganglionic eminences demonstrate blooming as well. So this looks like a case of a dysplastic megalencephaly, an mTOR pathway disorder. Some people refer to it as the mTORopathy. Now that brings me to the next category, which is malformations of cortical development due to abnormal cell migration. Now this can be further classified into heterotopia, which is under migration relative to the cortex, cobblestone complex, which is over migration relative to the cortex, lissencephaly plus minus band heterotopia, an entity that I have not seen so far, and therefore I'm not going to edit. And then tubulinopathy have been included in this category. So that brings me to a little bit of embryology. In the early stages, we have a two-cell layer. So this is going to be the level of the ventricle. Therefore, that's the ventricular zone, and then that's the preplate, intermediate zone in between. The cortical plate forms and splits the preplate into the marginal zone and the subplate. All of this happens in an inside-out manner. The cortex forms with the oldest neuron occupying layer 6. This is going to be the white matter, which is which would have been the intermediate zone in the preceding periods. And coming back to the neuronal migration, the oldest neurons occupy layer 6. The youngest neurons occupy layer 1. So if there is under migration relative to the cortex, we pick up this finding. Ultrasound demonstrated ventriculomegaly at 21 weeks, 3 days. We can see this subtle irregularity along the posterior, along the occipital horns, worse in the hemisphere on the left compared to the right side on the axial weighted image. It is nicely reproduced on the coronal T2 weighted image. Unfortunately, we did not get a good diffusion, but the point behind this image is to prove that these tend to be bright because they are heterotopic and they are gray matter heterotopia. They tend to have the same degree of brightness as the cortex. So you can, with the eye of faith, appreciate a subtle undulation along the ventricular margins here, which corresponds to the heterotopia. The differentials in this condition would be a subependymal nodule in the context of tuberous sclerosis, hemorrhage, etc. And then the postmortem MRI confirms the presence of the nodules that are seen on the fetal MRI. We got a diagnosis of LAMC3 mutation on that. Now, moving on, this particular ultrasound at 30 weeks demonstrated a microphthalmia and ventriculomegaly. Most of you would have got the diagnosis by now. This is a S-shaped brainstem, ventriculomegaly, loss of lamination, persistent fetal vasculature, which we added to the ultrasound finding, microphthalmia. And then we see this diffuse. At 30 weeks, I need to see more sulci here. There's virtually no sulcus, and you have this thickened cortex, both sides. You can see it there as well. The septum is not visualized, hence you have low fused fornices. Some people refer to it as the fornicial pseudonodule. And that's the postnatal MRI, which again reproduces all those findings that we saw. You can see the cobblestoning in the cortex bilaterally. And this is an extreme lateral image of the postnatal MRI, which shows those cobblestone appearances in the far sagittal as you are coming towards the surface of the cortex, where you can see those T2 dark areas. So that brings me back to the heterotopia, which was the LAMC3 mutation. Now that's the periventricular nodular heterotopia. And that is said to be the result of a defect in the basement membrane. If there are small defects, you develop a polymicrogyria like cobblestoning of the cortex. And if it is a huge defect, more neurons will pass through. The stop signal is not working, and hence the neurons do not know that they have to stop migrating, and they go past the glial limiting membrane and produce a pachygyric or a Lis-like cobblestone cortex. Now coming to tubulopathies, ultrasound again, ventriculomegaly, 21 weeks, axial T2 weighted image, and a coronal T2 here. We thought we had hook-like frontal horns. Not very confident about it, but thought it could be representative of tubulopathies. Mom went ahead and delivered the child, and to our surprise, it turned out to be positive for a TUB-A1A mutation, where you can see the like frontal horns, uncleaved basal ganglia, and absence of the anterior limb of the internal capsule on the postnatal MRI. A slight variation on the tubulopathy theme, which was this particular case where ultrasound showed ventriculomegaly and a cyst in the posterior fossa at 20 weeks, where you can see these cystic areas involving the ganglionic eminences. There is ventriculomegaly, thinning of the neuroparenchyma, significant thinning, seen on the coronal and axial T2 weighted images. And then a very, very thin brainstem, which almost has that S-like shape. And on a right parasagittal T2 weighted image, you can see a cyst in the posterior fossa. The differentials that we provided were Walker-Warburg syndrome and tubulopathy. And this one went ahead with termination. And this is the post-mortem MRI that shows those cystic areas in the ganglionic eminences bilaterally on the axial and coronal T2 weighted images. And again, reproduces everything that the fetal MRI showed. Now, when we discussed this case in our autopsy meeting, our pathologists mentioned to us that there were some ridges that were seen on those fixed specimen. And those ridges corresponded to these areas on the H&E stain on the histopathology. And they refer to those areas as areas of arrested neuronal migration. I've got a normal here for comparison. So we went back to our 3D data set and MIPed it, and we could see these dark lines that are seen radiating away from the ventricular margin. You can see that very beautifully on the sagittal T2. And then that's the area of the ganglionic eminence hemorrhage. So the differentials for that would be a tubulinopathy, an mTOR pathway disorder, tuberous sclerosis, PDHA1, and oligofrenin-1 mutations. Finally, malformations of cortical development due to abnormal post-migrational organization. Polymicrogyria and schizencephaly are the two in that category. And this is a case of polymicrogyria or evolving polymicrogyria, where ultrasound shows ventriculomegaly at 21 weeks and 6 days, where you sort of bumps along the cortical profile on the axial T2 weighted image, sort of a blister-like appearance and an irregularity here. Apologies, the arrow is right over the area of interest. To address this, there is a beautiful article that came out from Andrea Regini's team about evolving polymicrogyria. Incidentally, polymicrogyria is usually due to insult in late migration and early cortical organization, approximately 20 to 28 weeks. And if you have heterotopia associated with it, you would probably postulate that the insult was much earlier. So this was the article, and these were the various configurations that they put out: wart-like, sawtooth-like, invaginating sulcus-like, and bump-like, which are features that would evolve into polymicrogyria. This is thought to be due to perfusion failure provoked by an infection, most likely CMV, but could also be idiopathic or genetic. And coming to schizencephaly, this was diagnosed on ultrasound associated with septal agenesis at 21 weeks, where you have the open lip schizencephaly on the axial and coronal T2 weighted images, and on the sagittal, because you don't have the septum, the fornix has a horizontal course and is low lying, as I explained earlier. And this is confirmed on the post-mortem MRI, where you see all those findings. Important to remember here that the septum pellucidum embryologically corresponds to the frontal lobe, and therefore schizencephalic clefts are associated with septal agenesis. Now that brings me to the last few slides. Now start off with midline precursors. They develop at between 9 and 10 weeks. Which is the midline precursor. It's called the median groove, or sulcus medianus telencephali medii, SMTM for short. It's a prerequisite for the corpus callosum to develop. 9 weeks is also the time for the cerebellum to form, and 10 weeks is when the foramen of Magendie opens. So therefore it's possible to conceive that if there is an insult at 10 weeks, it would be associated with agenesis of the corpus callosum and a Dandy Walker phenotype. Matthew Whitehead will talk more about it. So this is a case of agenesis of the corpus callosum, where you don't have the crossing over of the corpus callosum on the coronal T2 and the classic finding of the bull horn appearance to the frontal horns. But in addition to that, we also found bumps or warts in the cortical profile. And that's all seen very nicely on the postmortem MRI, all that. And that entire medial aspect of the right hemisphere is bumpy. We are still awaiting the histopath on this. Another case of agenesis of the corpus callosum at 22 weeks and 3 days, picked up on ultrasound, but and then customary MRI performed after the ultrasound that shows this thin tissue going across the midline. That's that straight line there, which is the hippocampal commissure, which is seen in cases of agenesis of the corpus callosum. That's the postmortem MRI that shows the yellow arrows pointing to the hippocampal commissure. Now, it's very important to remember that agenesis of the corpus callosum is not the actual true term. It has to be classic commissural agenesis. The reason is the corpus callosal fibers are not truly agenetic. They are there, but they have been routed in an abnormal direction. So if you think about it, the corpus callosum is a commissural tract connecting point A in one hemisphere to point A in the contralateral hemisphere. Now coming to the midline, and if they don't find the medium to cross over, what they would do is connect point A of one hemisphere to point Z of the same hemisphere. This is just for argument's sake. So the corpus callosal fibers are there. They're just routed abnormally. What is missing is a commissural plate. Therefore, a better term is classic commissural agenesis. And I would refer you to Dr. Charles Rebo's seminal article, and prior to that, the article by Rakic and Yakovlev. It will clear all the doubts with respect to corpus callosal development. In this particular case, we also found an aberrant frontal sulcation, which we couldn't pick up on the fetal MR. Therefore, it's important to use the term classic commissural agenesis and not agenesis of the corpus callosum. It's not purely an axonal navigation issue. So if you break it down into the different parts of the neuronal migration process, it could start off at a point where the neuronal proliferation or apoptosis period begins, where there is absence of dedicated callosal neurons, or the callosal neurons are there, but they have failed to migrate in the phase of migration. Coming to the phase of organization, the callosal neuron might go to the proper location in the cortex, but instead of developing a commissural axon that crosses the midline, it might be just a subcortical axon that comes off, and hence you don't have a corpus callosum. Or it has sent a commissural axon, but it is not able to cross because there's a massive heterotopia, or there is an interhemispheric meningeal lipoma, or the contralateral hemisphere is not permissive and it's not going to receive an axon for whatever reason. Therefore, corpus callosal agenesis, or better called classic commissural agenesis, is not purely an axonal navigation issue. Coming to our last few slides, ventriculomegaly at 22 weeks and 2 days, the ultrasound shows ventriculomegaly. So we did an MRI that shows this sort of hypersulcation of the temporal lobes, brachycephaly, frontal bossing, and this is a slam dunk for a diagnosis of thanatophoric dwarfism. This is a post-mortem MRI that shows again the bilateral temporal lobe hypersulcation, and an FGFR3 mutation was identified. That's the autopsy image that shows the accessory sulcus in the temporal region, and the fetogram that shows all those changes of rhizomelic dysplasia. So the take-home points are important to have a good hold on the biometry. Laminations have to be checked, 5 in supratentorium over 20 weeks at least, and all 3 on the diffusion-weighted imaging. Assess the ventricular margins for heterotopia. Schism-cephalic clefts in the frontal regions can be associated with septal agenesis. And my favorite, classic commissural agenesis, is a better term than agenesis of the corpus callosum. With that, I thank you for your attention, and I'll be hanging around for a while to take any questions.